The landscape of somnambulism presents a curious state of mind. It is far more than simple sleepwalking. Historically, it deeply puzzled early physicians. They saw it as a window to altered consciousness, a profound shift in a person's being. Carl Jung in his early work explored such states. He sought to understand these hidden mental landscapes. These conditions challenged the nascent field of psychiatry. Neurotic disorders formed a broad, encompassing category. They included anxieties, obsessions, and unusual bodily symptoms. Somnambulism was often placed within this varied group. Its nature seemed tied to nervous system sensitivities. The term neurotic implied a functional, not organic issue, yet the lines were frequently blurred and indistinct. Understanding these conditions was a formidable task. The mind's workings remained largely mysterious then. Jung's initial investigations focused on these very puzzles. He was fascinated by the unconscious mind's power. Somnambulism seemed a direct expression of it. It bypassed the usual conscious awareness. Such phenomena offered clues, however enigmatic. They hinted at processes operating beneath the surface. These early studies laid groundwork for later theories. The exploration of the psyche was just beginning. The central issue was diagnostic clarity, or its lack. Somnambulism shared features with other conditions. Hysteria, epilepsy, even neurasthenia showed overlaps. Distinguishing them required immense clinical skill. This essay delves into these complex interrelations. It aims to explore these fascinating historical challenges. Understanding these overlaps remains vital even today. It informs our approach to complex mental states. True somnambulism extends beyond ordinary sleepwalking. It involves a distinct, trance-like condition. Individuals may perform very complex actions. They might speak, write, or interact with surroundings. All this occurs without full waking consciousness. The person appears awake yet is not truly present. Their eyes might be open yet unseeing. This state held a deep fascination for early researchers. A key feature is the altered state of perception. Memory during these episodes is often fragmented. More commonly, there is complete amnesia afterwards. The individual has no recollection of their actions. This disconnect between action and memory is striking. It suggests a division within the conscious experience, a splitting or dissociation of mental functions. This was a core puzzle for Jung and his contemporaries. Psychologically, somnambulism was thought to stem from deep sources. Some linked it to wish fulfillment or hidden desires. Others saw it as an escape from intolerable stress. The subconscious mind seemed to take temporary control. It expressed what the conscious mind could not. These interpretations were, of course, speculative, yet they tried to make sense of baffling behaviors. The inner world of the somnambulist remained elusive. It is crucial to differentiate this from simple nocturnal wandering. Ordinary sleepwalking is usually less complex, more automatic. Somnambulism, particularly in historical accounts, could be different. Some reports described a somnambulistic lucidity. Individuals might display heightened sensory awareness, or they might access memories unavailable in waking life. These accounts added to the state's enigmatic nature. They suggested more than just an absence of consciousness. Epilepsy is primarily a neurological disorder. It is characterized by recurrent, unprovoked seizures. These seizures result from abnormal brain activity. Manifestations can vary widely among individuals. Some are convulsive, others are more subtle. The condition has a long and often misunderstood history. Its symptoms can sometimes be profoundly disorienting. This created overlaps with other perplexing states. Certain epileptic seizures mimic somnambulistic behavior. Temporal lobe epilepsy is a notable example. It can produce automatisms, non-purposeful repetitive actions. A person might pluck at clothes or make chewing motions. They may wander in a confused, fugue-like state. Consciousness is impaired during these episodes. Afterward, memory for the event is often poor. These features bear a resemblance to somnambulism. Historically, this similarity caused considerable confusion. Distinguishing between an epileptic fugue and a somnambulistic trance was hard. Both involved altered awareness and unusual actions. Both could leave the individual with no memory. The underlying cause, however, was quite different. One pointed to neurological disruption, the other perhaps psychological. but the outward signs could appear deceptively alike. Clinicians faced a significant diagnostic challenge. This diagnostic difficulty underscored the need for careful observation. Physicians like Jung had limited technological tools. Diagnosis relied heavily on detailed patient histories. Witness accounts of episodes were also crucial. Any subtle differences in presentation were noted. The presence of an aura before an event might suggest epilepsy. The psychological context might point towards somnambulism. Yet certainty was often an elusive goal. Hysteria, as understood in Jung's time, was a complex diagnosis. It was a term for a wide array of symptoms. These symptoms often lacked a clear physical cause. They could include paralysis, blindness, or convulsions. Emotional volatility and suggestibility were also common. Jean-Martin Charcot's work at the Salpêtrière greatly influenced views. He famously demonstrated hysterical symptoms to audiences. Hysteria was seen largely as a disorder of women. Many hysterical manifestations closely mirrored somnambulism. Dissociative states were common in hysterical patients. They might enter trance-like conditions spontaneously. Fugue states where individuals wander aimlessly occurred. They would have no memory of these journeys later. These episodes could be indistinguishable from somnambulistic ones. The term hysterical somnambulism even came into use. It described this profound overlap in presentation. The connection was thought to be deeply psychological. Hysteria often seemed to involve a splitting of consciousness. Unbearable emotions or traumatic memories were repressed. They then manifested as physical or dissociative symptoms. Somnambulism in this context could be one such manifestation. The body or mind enacted what could not be consciously faced. This view aligned with emerging psychoanalytic ideas. It suggested a common root for diverse symptoms. The overlap made diagnosis extraordinarily challenging. Was the patient truly somnambulistic in a primary sense? Or was the somnambulism a feature of underlying hysteria? The patient's history and psychological makeup were scrutinized. Suggestibility was a key factor often tested. Hysterical symptoms could sometimes be induced or alleviated by suggestion. This was less typical for other conditions. But even this was not an infallible guide. Section 5. Nerves unstrung. Neurasthenia's intersection with somnambulistic states. Neurasthenia was a common diagnosis in that era. Coined by George Miller Beard, it meant nerve weakness. It was thought to result from exhaustion of the nervous system. The pressures of modern life were often blamed. Symptoms were varied and often vague. Chronic fatigue was a hallmark of the condition. Headaches, anxiety, and irritability were also frequent. A general sense of malaise pervaded the sufferer's life. The link between neurasthenia and somnambulism is less direct. It is not as dramatic as with epilepsy or hysteria. However, profound mental and physical fatigue can alter consciousness. Extreme exhaustion might lower the threshold for dissociative states. A neurasthenic individual, already depleted, could be more vulnerable. They might experience milder forms of mental detachment or perhaps automatic behaviors akin to somnambulism. Their mental energy was simply too low to maintain full presence. The shared ground was often one of general mental fogginess. Neurasthenic patients reported difficulty concentrating. Their thoughts could feel slow, their perceptions dulled. This state of reduced mental clarity might blur into dissociation. It could make it harder to distinguish subtle somnambulistic features. The individual might not clearly recall periods of activity, not due to a distinct trance, but to pervasive weariness. The boundaries of awareness became less defined. Diagnosing these subtle states was exceptionally difficult. Was the patient's detached behavior part of their neurasthenia? Or was it a separate coexisting somnambulistic tendency? The treatments also differed, complicating matters. Neurasthenia called for rest, tonics, and lifestyle changes. Somnambulism might prompt psychological exploration. Understanding the interplay was vital for appropriate care. The exhausted mind presented its own unique challenges. Section 6. A tangled web, the perils of diagnosing dissociative conditions. The core problem remained the profound symptom overlap. Somnambulism, epilepsy, hysteria, neurasthenia all shared traits. Altered consciousness was a common thread. Memory disturbances were frequent across these conditions. Unusual behaviors, not under voluntary control, also occurred. This made differential diagnosis a true clinical art. It required patience, keen observation, and deep empathy. The physician had to navigate a complex web of signs. Diagnostic tools in the early 20th century were limited. There were no brain scans or sophisticated neurological tests. Clinicians relied heavily on the patient's own account. They also gathered information from family members. Detailed note-taking of behavioral patterns was essential. The specific nature of the trance or fit was scrutinized. Were there triggers? Was there an aura? What was the patient's state upon waking? The subjective nature of many symptoms added another layer. Patients described their experiences in varied ways. Their reports were filtered through their own understanding and through the prevailing cultural beliefs about such states. The clinician's interpretation was also a factor. Preconceptions or theoretical biases could influence judgment. This human element was unavoidable in the diagnostic process. It made consistency and objectivity difficult to achieve. Misdiagnosis carried significant risks for the patient. If epilepsy was mistaken for hysteria, proper treatment was denied. Anticonvulsant therapies, though rudimentary, were emerging. If hysteria was treated purely as a neurological issue, psychotherapy was missed. The psychological distress would remain unaddressed. Each condition ideally required a different therapeutic approach. An incorrect label could lead to years of ineffective care. The stakes were therefore exceptionally high. Section 7. Through a Glass Darkly, the case of Elise K. and diagnostic riddles. Consider the hypothetical case of Elise K. She was a young woman in her early 20s. Her family reported episodes of nighttime wandering. During these, Elise would rearrange furniture. She sometimes spoke, but her words were nonsensical. She had no memory of these events afterwards. This initially suggested a clear case of somnambulism. Her physician, Dr. Weber, began his careful investigation. However, Elise also displayed other troubling symptoms. She suffered from sudden, inexplicable paralyses of her arm. These would last for hours, then vanish. She was also prone to fits of weeping, and she described brief moments of absence. During these, she would stare blankly for a minute. These features clouded the initial diagnostic picture. They pointed towards possible hysteria or even petit mal epilepsy. Dr. Weber meticulously documented Elise's history. He interviewed her parents and siblings at length. He learned of a recent emotional trauma. Elise had lost a close friend unexpectedly. He observed her reactions to various stimuli. He noted a degree of suggestibility. He also considered the possibility of epilepsy, but there were no convulsions, no clear post-ictal confusion. Ultimately, Dr. Weber leaned towards a diagnosis of hysteria. He felt the somnambulism was one facet of it. The paralyses and emotional ability supported this. The absences seemed more dissociative than epileptic. He proposed a course of supportive psychotherapy. He also recommended a change of environment for Elise. The case of Elise K. highlights the era's diagnostic haze. It shows how symptoms could point in multiple directions. Section 8. The Compass of Diagnosis. Guiding treatment in neuropsychiatry. An accurate diagnosis is the bedrock of effective treatment. This was as true in Jung's time as it is now. Without a clear understanding, interventions were often haphazard. They might be ineffective or, worse, detrimental. The physician's first duty was to try and name the affliction. This naming, however imperfect, provided a starting point. It offered a framework for thinking about the illness and for selecting the most promising remedies. Treatments varied considerably based on the diagnosis. Neurasthenia might be met with rest cures and hydrotherapy. Tonics and electrical stimulation were also popular. Hysteria, especially after Freud's influence grew, prompted talk therapy. Hypnosis and suggestion were used to access repressed material. The aim was to uncover underlying psychological conflicts. Epilepsy, if recognized, might be treated with bromides. These early sedatives could sometimes reduce seizure frequency. The consequences of misdiagnosis could be severe. Imagine treating a patient with temporal lobe epilepsy for hysteria. Psychotherapy would likely offer little relief from seizures. The underlying neurological issue would persist. Conversely, treating a deeply traumatized hysterical patient with sedatives, this might dull their distress but not resolve its source. The patient's suffering would continue, perhaps deepening. The right path to healing depended on the right signpost. Understanding these overlaps, even with limitations, was crucial. It pushed clinicians towards more nuanced assessments. They learned to look beyond single, striking symptoms. They began to appreciate the whole person. The patient's life story, their stresses, their personality, all these became part of the diagnostic equation. This holistic view was a vital step forward. It paved the way for more sophisticated psychiatric understanding. Section 9. Horizons of Understanding. Reflections on psychopathology's complex terrain. Early 20th century clinicians faced immense challenges. Diagnosing somnambulism and related conditions was arduous. The overlap of symptoms was a constant impediment. Epilepsy, hysteria, and neurasthenia often wore similar masks. Disentangling them required exceptional skill and patience. The human mind and its disorders presented deep mysteries. These pioneers worked at the frontiers of knowledge. Their efforts laid crucial foundations for future progress. Jung's early work on psychopathology is significant here. His detailed case studies, like that of his cousin Helene Preiswerk, explored these complexities. He demonstrated a keen eye for subtle psychological processes. He was unafraid to delve into the subjective experience of patients. These investigations highlighted the need for deeper understanding. They showed that surface symptoms could be misleading. The inner world of the patient held vital clues. This approach was revolutionary for its time. Our understanding has undoubtedly evolved since then. Modern diagnostic tools offer unprecedented insights. Electroencephalography (EEG) can detect abnormal brainwaves in epilepsy. Neuroimaging techniques can reveal structural and functional brain changes. Psychiatric diagnostic criteria are more refined and standardized. Yet some fundamental challenges persist even now. Distinguishing subjectively experienced states can still be hard. The mind-brain relationship remains incredibly complex. The work of early explorers like Jung remains relevant. It reminds us of the importance of careful clinical observation. It underscores the need for a holistic view of the patient. We must listen attentively to their stories, the intricate connections between mind, brain, and behavior. These continue to demand our curiosity and diligent research. Illuminating psychopathology's terrain is an ongoing journey. Each generation builds upon the insights of the past.